Mohamed.
Yes, Hassan, I'm trying to share this. I'm sharing my screen.
Okay, take your time. Mhm.
So,
Welcome.
first, I'd like to thank Dr. Hassan for his invitation. Always in this journal club, we always learn from this journal club from our professors. Today, we will try to have an interactive session about practical tips in the management of severe obstructive lung disorder exacerbations, as either severe bronchial asthma or severe COPD exacerbation. So the first rule in this lecture, it's an interactive lecture. So please feel free to unmute yourself and interact whenever you need. Okay, this is an interactive session. We don't have an agreement actually in the ventilatory support or ventilatory management in many things. So feel free to interact and to object or to say your opinion about this, about what we are saying in this lecture. Um, our objective of our lectures, first we will try to reduce the non-practical part of this topic. So we will pass through the definition of the bronchial asthma, definition of COPD, and the diagnosis of exacerbation. We will pass through this rapidly. We'll try to concentrate on the ventilatory management, investigations and role of pulmonary function test in diagnosis of exacerbation is a very important topic, but this is beyond our talk today. The management, we will talk about the prevention, but rapidly. The destination of therapy, we are going to talk about the patient who are going to be admitted inside the ICU. And pharmacological management also will be beyond of our talk today. We will concentrate on this single topic, the respiratory supportive measures we can take and we can manage a patient with a COPD exacerbation or a bronchial asthma severe exacerbation. So this is our topic today. So, as an introduction, we should know the history that the respiratory distress was a very important topic even in the old era. It was first recorded in China 3,000 years ago. They just said and they just named it as a noisy breathing. The asthma was defined for them as a noisy breathing. And actually, the emperor of China 3,000 years ago was the first person to try a treatment for bronchial asthma or bronchial asthma exacerbation. He tested the ephedra plant. This is a well-known plant, which is which has a treatment for the asthma. So this was the first line of treatment of bronchial asthma 3,000 years ago. Ancient Egyptians, 2,000 years ago, also considered respiration was one of the most crucial function in the human body, and they had many treatment for this problem. Hippocrates, which we all know for his oath, we all use his oath in our early career, was the first person who tried to understand the correlation between the environment and the respiratory problems and the asthma attacks. He also recommended ephedra, like the Chinese, along with red wine. We don't recommend red wine, by the way, or any wine for the treatment of asthma. In Europe, tobacco was introduced as a treatment of asthma. Now it's the cause, but it was introduced at first as a treatment of asthma. So we'll pass through this historic review, and we will go through our important ventilatory management of asthma. So what if we have an asthmatic patient or a COPD patient with a severe asthmatic attack? We will have two cases that will go through with us, and I want to know your opinion about their initial management plan, respiratory management plan, not the pharmacological management, because this is beyond our scope of talk today. So we will have two two case scenarios, and I want to know your opinion about the difference in respiratory support between them. The first case is a male patient. I don't know if my slide is appear to the meeting or no. All of you see my slides? Slide
Yes,
one. Okay.
yes.
Yes, sir. Yes, sir. Yeah, yeah.
We have a male patient, Mr. Y. He's a chronic heavy smoker. He has a recurrent ICU admission, previous non-invasive mechanical ventilation in his last admission. He is admitted now with dyspnea, most probably COPD exacerbation. Uh, his respiratory rate is 35. He is distressed even after taking 3 sessions of bronchodilators. His actual body weight, when we weighted him, it was 80 kilogram, and we estimated his ideal body weight by calculation about 90 kilogram. And this is his X-ray. What do you think about his X-ray? Anyone can comment. What do you think about this X-ray?
Hyperinflated.
Hyperinflated sheet.
Hyperinflated, a typical X-ray of a COPD patient. Actually, I cannot see, يعني maybe an evolving pneumonia too, but it's not a complete form, well formed lobar pneumonia. This is his blood gases. What do you think about his blood gases? This is his blood gases on non-rebreather mask. The ED doctor or the emergency doctor started a non-rebreather mask, and this is his blood gas. Yeah, it's showing
Respiratory acidosis.
respiratory acidosis. Okay.
Metabolic complaint.
Okay. What do you think about your respiratory support plan in such a patient? What would you consider as a respiratory support plan in such a patient? Does he need an extra respiratory support, or you are convenient with this level of support?
Non-invasive.
Non-invasive ventilation. Okay. What's your rationale and what's your alternative? So you are not convinced with only giving him oxygen supplementation with the regular oxygen device, the oxygen mask, although his oxygenation is fair. His saturation is 89 and his PaO2 arterial partial oxygen tension is 59 millimeter mercury. So you want to elevate the level of respiratory support. What's your rationale?
If you
Yeah,
give oxygen,
I'm
it
not
will
objecting. Maybe I agree with you, but what's your rationale?
Non-invasive ventilation is the first line treatment for patients with COPD exacerbation. It
Yes.
has a very high level of evidence in these cases.
So we have a level one recommendation to start non-invasive in COPD exacerbation. But do you think this degree of exacerbation necessitates a higher level of respiratory support?
No.
No. Why no?
pH 7 7.3.
So you are talking about the blood gases and ventilatory evaluation by blood gases, but take care of this clinical data. His respiratory rate is 35. He is distressed, so the work of breathing is very high, despite receiving 3 sessions of bronchodilators. So it's not a matter only of oxygenation because they have an adequate oxygenation in this case, and it's not a matter only of CO2 and pH correction, but here is we do have a matter of work of breathing. So I do agree with the one who said non-invasive ventilation. Maybe it's not only for correcting the blood gases measurement, but it's here for the work of breathing and for the and you have the evidence for this. Does anyone have any other modality for such a patient in such a
Maybe high
lactate, we
flow.
have to see.
High
Lactate, we
flow
have to
nasal
see.
cannula is
high
not
flow
tolerating.
nasal cannula? High flow nasal cannula is a good choice actually, especially in rather stable COPD patient or mild exacerbation. So in the early years of the high flow nasal cannula, it was only planned for the hypoxemic respiratory failure patient. It was almost contraindicated in hypercarbic respiratory failure patient. But 2016, 2018, 2020, many trials recommended or high flow nasal cannula usage in hypercarbic respiratory failure patients, especially in COPD exacerbation. We will talk about this later, about the rationale, about the evidence in using this. What about invasive ventilation in such a case? Do you think is a candidate for invasive ventilation?
I think before invasive ventilation, we can
Not yet.
try BiPAP
Not yet.
as a non-invasive.
So you agree with the non-invasive ventilation. So let's go to another case. Okay. It's a little bit similar to this case, but there's main difference in the history. We have a female patient, Mrs. X, with history of bronchial asthma on regular medication. She was admitted with dyspnea, asthma exacerbation, and severe respiratory distress. Her respiratory rate is 30. She's also received 3 sessions of bronchodilators. This is her body weight, and this is a similar blood gases, also on non-breather mask, or let's consider it in nasal cannula even. So, what do you think about the difference in respiratory management in both cases?
Here she needs
Does this
intubation.
patient need a third or what?
invasive
I think she needs intubation or mechanical يعني invasive ventilation. She's
She needs
retaining CO2.
invasive mechanical ventilation for retaining a CO2. What about trying a non-invasive ventilation in such a case, or high flow nasal cannula like the other patient we just talked about? What do you
In
think?
asthma, in asthma we don't.
Can do it.
In
In
asthma patient,
asthma,
we don't use.
let's hear each other. We don't use non-invasive ventilation in asthma, or we expect a lower outcome in asthma. Let's
Lower outcome.
yeah. So a patient with a severe asthmatic attack. Actually, we don't see too much asthmatic attacks these days. When I was in my early career, maybe something like 15 years or 20 years ago, I've seen many bronchial asthma patients. But because of the newer medication and the compliance of the patient, I rather do not see a severe asthmatic attacks like the old years. But if we have a severe asthmatic attack patient with a respiratory failure, what do you consider a non-invasive ventilation, or you don't use it in your practice? It does not have the very high evidence like the COPD patient, but you should not prevent the patient, the patient of asthma, from non-invasive trial. But please do not delay the intubation in such a patient. He's more difficult to ventilate than the COPD patient. But this patient might benefit from non-invasive or not. This is specific patient. What do you think? You can unmute yourself, okay? Because I cannot read the full chat. Yes, somebody is telling this is a near fatal bronchial asthma. What's the difference here? Because the last patient, we said this, the COPD patient with the similar blood gases, we just said that this is a mild exacerbation of COPD, but in this patient, we said that this is a fatal as a near fatal asthma. What's the difference here?
There is severe respiratory muscle fatigue.
في respiratory muscle fatigue. Okay.
ممكن
ineffective
نون
ventilation.
انفيزيف بس ممكن يبقى كلوز
So
جاهزين بالانتيوبيشن والميكانيكال فنتيليشن لان السي او 2 رايز فيه دوت بيقول ان خلاص البيشنت فاتيكد مننا وهو دخل اصلا في ريسبيراتوري فيلير فلازم ننشيت ميكانيكال فنتيليشن او ننشيت نون انفيزيف بس بكلوز مونيتورنج في الاي سي يو.
okay. So let's start talking about our practical tips in initiation of mechanical ventilation in obstructive lung disease in general. Either the obstructive lung disease is bronchial asthma exacerbation or a severe COPD exacerbation. So first of all, we have seven stepwise approach of starting or initiation of mechanical ventilation in this obstructive lung disease. Step one, using non-invasive or invasive, the brand of your device. Sometimes the general concepts of mechanical ventilation are almost universal among all the devices, but sometimes the devices or the company have a different nomenclature between the different devices. Even in the same, if you have the same mode, sometimes it have different features in different modes. So before starting any ventilation to any patient, either obstructive or non-obstructive lung disease, you should be familiar and have a proper training in using your device, the device you are using. Not only a general training about mechanical ventilation, but a specific training using your device. Step two, you should check. We will go through these steps in details, but you are just mentioning our objectives or line of treatment or line of initiation of mechanical ventilation. Step two, you should have an objective indication of initiation of mechanical ventilation. This device is a respiratory support modality, but sometimes it's harmful. So as much as you can, sometimes it's very difficult to have an objective indication, but as much as you can, you should have an objective indication for the initiation of mechanical ventilation in your patient, especially the asthmatic patient. Okay, but the COPD patient, maybe it's an easier to have an objective indication, and you should think about alternative respiratory supportive modalities. So think about them. Are they useful? Can we use the Venturi mask, the nasal cannula? Does he need an extra respiratory support, or he needs a ventilatory support in such a patient? So think about objective indication and think about alternative for this respiratory support. Step three, this is very essential, is to choose the appropriate interface. So, in obstructive lung disease exacerbation, especially the COPD, the non-invasive interface, the face mask, whatever the interface you're using, is usually has a high success rate in COPD patients. So you should choose your appropriate interface, non-invasive or invasive in your patient. You should have a clear algorithmic thinking about the use of non-invasive interface in obstructive lung disease exacerbation. And if you are using a non-invasive interface, you should use a proper sized interface. This is also, and you should have different interface sizes and different interfaces in the non-invasive usage. Step number four, after choosing the interface, non-invasive or invasive, you should choose a proper initial mode. We'll talk about this in detail. And after choosing the mode, you should set up the initial setting that fits with your patient targets. Initial setting depend on the lung, the disease you have, and depend on the initial mode you choose. Step number six, do not forget to set up the alarm so it can tell you about the problems in the patient. And the last step is monitor your goal achievement and your patient response. And a special care in obstructive lung disease, you should monitor for the O2P. So we shall go through the journey through these 7 steps. Yes, my friend Ariel, you should know the mechanical ventilator strategy for the specific disease. Yes. So we will go through these 7 steps rapidly. Okay. We have what's the modalities of respiratory support we have in our usual care. First of all, we have the oxygen delivery device, simple oxygen delivery device like the nasal cannula and the simple face mask, the non-rebreather mask, and the Venturi mask. In our 2 cases, we started using non-rebreather mask in our 2 cases because they were hypoxemic upon admission, severely hypoxemic, and we used the non-rebreather mask. But this simple oxygen delivery device can correct hypoxemia, but it does not add too much to the work of breathing. The problem in our patient here was the work of breathing. So these the modalities would not fit in our patient problem in the cases we got. We have the high flow nasal cannula. The important or the physiological rationale in high flow nasal cannula in such obstructive lung disease is the chemical dead space. Can wash out the carbon dioxide from the upper airway and reduce the rebreathing, actually. And somehow, using this high flow, generates a positive airway pressure, something like a PEEP effect. This can improve the alveolar recruitment and improve the dynamic airway collapse. It's also helpful maybe more helpful than the non-invasive ventilation in improving the mucociliary clearance, especially in patients with chronic bronchitis who have thick secretions. So clearing the secretion with the high flow nasal cannula is much better and much easier than using the non-invasive interface. Also, it's had a better comfort and tolerance, so it can be used. It can be used as a line of management, although the evidence in the COPD patient is moderate, not like the non-invasive ventilation, but we don't have a good evidence actually, or to my knowledge, in the asthmatic patient or the asthma exacerbation, but it can be used. Mechanical ventilation, the level 2 of the respiratory supportive modalities, we have the negative pressure ventilation. We are not using in our country actually, but it's not helpful in such situation. It may be helpful in a chronic patient with chronic respiratory muscle weakness so we will not use it. Positive pressure ventilation, non-invasive and invasive mechanical ventilation are very good choices. The first choice in our case here was the non-invasive ventilation because in the COPD patient. But I think in such asthmatic patient, we should consider early invasive ventilation. So this is the level 2 of respiratory support. We have an advanced techniques like the extracorporeal life support, ECMO, extracorporeal membrane oxygenation, and ECOR, extracorporeal carbon dioxide removal. So these are not found in every center and not actually available in every center, but we can use them as a salvage technique. They have some evidence as a salvage technique in severe COPD exacerbation patient, and sometimes they are used in severe asthma patients. They have some little evidence in asthma patient, but they can be used as a salvage technique, the extracorporeal life support technique. Hyperbaric oxygen therapy has no role in our situation, but there are some adjuncts like the airway management and airway clearance technique and cough assist device. They can be a little bit helpful, but in such patients. So let's start the 7 tips in management. First of all, you should be, as we said, we should be very familiar with your device. Why this is very important? Because sometimes similar modes, the mode you are using very much in the Hamilton ventilator on the Drager ventilator has a different nomenclature in another device. So you should be familiar with your device. Currently, we have the taxonomy of mechanical ventilation, so we can know that this mode is similar to this mode. But if you don't know yet this taxonomy of modes, you can at least be trained on your ventilator and know the nomenclature of the modes in your ventilator. Okay, so a better option is using a mode taxonomy to identify your mode. But even if you know your mode, very properly, sometimes the same mode in different devices have different settings, have different buttons to set. So the mode, we can see here an example of 4 devices. A servo eye device, and it's not an advertisement. Just we have no conflict of interest, but this is just for demonstration. So we have a servo eye on the upper left panel, and the Drager ventilator, and the Bennett ventilator, and the Mindray ventilator. The same mode. This is a volume control mode, or a VC, CMV. S or D according to the taxonomy. But although this is the same mode, but it have different button and different setting. So if you are not used or you are not trained to your device, you can say you are always using a Drager ventilator. You will find the different modes, different buttons in the same mode than the Hamilton, than the Drager, than the Bennett. So you should be trained on your device. Not even this, but sometimes setting a similar button is different from device to another. We have a Bennett ventilator on the left side and a Drager ventilator on the right side, and we are pointing to the flow button. We are the peak inspiratory flow button. You are going to set the peak inspiratory flow differently in these different ventilators. Although this is the same mode, volume control mode or CMV mode, but you are going to set the same button differently because it have different function between the two different ventilators. So our message here is not going, we are not going in details in the differences between these brands, but be familiar with your device. It's very important because the nomenclature differs, the buttons differs, and even the same button you are using in the different ventilators can be set differently between a device and another. So this is the first message we can get from here. Remember that the respiratory support modality and the mechanical ventilation is not a treatment of your pulmonary disease. It's not a treatment. The ventilator does not treat the COPD exacerbation. It does not treat the pneumonia. It's just a bridge to the recovery of the patient. So this ventilator you are using is not a treatment. It's not an actual treatment of the obstructive lung disease problem or your problem. It's just a bridge to the recovery. This is a very important message you should get. But actually, it's not just a bridge. it sometimes causes you a harm in your lung. So this is, you should be familiar with this. So this is step one. You are familiar with your device and you have the patient, the COPD exacerbation patient or the asthmatic patient. Step two is to check for the objective indication to start the ventilatory support to your patient. Because as we said, this ventilatory support is not a treatment for the initial disease. Actually, it's not just a treatment, it's harmful sometimes for the lung if it's used for a long time or used improperly. So you should have an objective indication to start this ventilatory supportive technique. So we don't have an agreement about the objective indication of mechanical ventilation. We're just going to have some simple um, um, common indications. So indication number one, if the patient have an apnea or respiratory arrest. So he's apneic or have a respiratory arrest, he, you are willing to give him a heavy sedation, sometimes in severe asthmatic attack or in severe COPD exacerbation. First line and second line and even third line pharmacological therapy does not have a good result. So we are going to proceed to sedating the patient. Or if your patient have a cardiac arrest, so this is indication number one. Indication number two, in patient with a high CO2 and a low pH that is not improving with a non-invasive modality. So you have an acute hypercarbic respiratory failure that is not improving to the non-invasive techniques. Or you have a hypoxemic respiratory failure and you cannot reach your target PO2 despite initial techniques or despite your initial non-invasive techniques, either oxygen supplementation or non-invasive ventilation. You are still below the target saturation. Your saturation is not holding to 85% or 86% despite using the maximum non-invasive respiratory support. Another indication is the high work of breathing. This is an impending ventilatory failure. You cannot wait for the patient to, you have a very high respiratory rate for a long time and it is not improving using the non-invasive ventilatory support, either the high flow nasal cannula or the non-invasive ventilation. So this is a common objective indication for mechanical ventilation. Indication number five is the hemodynamic compromise. You have a refractory shock with the respiratory failure, so or without even the respiratory failure. So a mechanical ventilatory support will decrease the cardiac output going to the pulmonary or the lung, and so can improve the hemodynamic compromise in some patients. Although using ventilatory support in other hypovolemic patient or fluid non-responder, fluid responder patient, sometimes will cause more hemodynamic compromise. So this is a double-edged weapon here, so take care of this indication. Indication number six is the patient who cannot protect his airway. His Glasgow Coma scale is persistently low. He cannot protect his airway, so an intubation plus invasive ventilation sometimes is an option in such patient. So this is the second step of the management. First step, we are familiar with our device. Second step, we choose, we have an objective indication. The third step is the choice of the interface. So choice of interface or the favoring one of those two interfaces, the non-invasive versus the invasive. In my opinion, in any patient, you should consider, not use, consider the non-invasive interface before using the invasive interface. Because most of us in our practice, when we say mechanical ventilation, what comes in your mind is the endotracheal tube plus the sedation and invasive mechanical ventilation. This is not appropriate. Actually, the appropriate way of thinking is thinking first about the non-invasive interface as the first line. The invasive interface when the non-invasive fails or when it's contraindicated. So think about this. And usually a common practice, we use non-invasive interface in our COPD patient for a 1 hour check test. This is sometimes it's called. So you use it for 1 hour. You monitor the hemodynamics. You monitor the respiratory rate. You don't need to monitor the ABG improvement. Actually, if the patient after 1 hour is stable and improving, so you can continue on the non-invasive interface. But if he's facing problems during the first 1 hour, or is not convinced, he is not compliant to the non-invasive, you can shift to the invasive interface. So regarding our first patient, the patient with the COPD exacerbation, non-invasive interface is a proper choice. But and using a proper mask size, sometimes we have a full face mask, we have an oropharyngeal mask like this. It does not have a general rule, but an oropharyngeal mask is even less fear for claustrophobic patients, and the proper sized mask is mandatory. The essential element in using this mask is not making it very tight. You need to make it very tight. Most of our junior colleagues make it very tight to avoid leakage. This is not very important actually. In most of the modern ventilator, they compensate for the leakage. So you can allow a minor leak to improve the comfort or the convenience of the patient for this interface. So this is step number two. This is number three. After you is choosing the interface, we are either using a non-invasive interface like our previous case, or an invasive interface like the asthma case, which failed the non-invasive. You should choose the mode. So usually I prefer to start with a conventional mode, one of the four conventional or mode we are always using. Either a volume control mode or a pressure control mode. I don't prefer SIMV mode, but and not me. Even the literature does not prefer SIMV mode, but and or spontaneous mode. So if you are going to use an invasive interface, so you are going to use a full ventilatory support controlled mode, either volume control or pressure control. What do you think, in your opinion, in an obstructive lung disease is preferable? Uh, do you prefer
Pressure.
to use pressure control mode or volume control mode in an asthma patient and in the COPD patient? I want to hear from you. Do your
Pressure
patient
mostly.
failed the non-invasive? He cannot use the non-invasive interface. So you intubated the patient, and now you are considering a controlled mode that is an initial mode because you use the rapid sequence induction. Pressure mode. Why you are going to use pressure mode? What's the competitive edge in the pressure mode that does not have that you don't have in the volume mode?
I can avoid biotrauma for the lung.
You can avoid barotrauma. I think you can avoid biotrauma even
Volume.
in volume control mode. If it's properly set, you can avoid volume control in pressure control or volume control. What do you think the points of the competitive edge in pressure and the better things in the volume control mode? What do you think?
Flow is decelerating.
depends
Flow
from
is
A to B.
decelerating.
You control the
It
Ventilatory.
is more
So,
physical
we
for the
can
patient.
we can hear each other because we don't have actually. I don't think we all have an agreement on the initial mode. So some will prefer pressure and some will prefer volume control mode in such cases. So I want to hear from you your practice and your rationale for this practice. Your practice. What do you use in such obstructive lung disease and asthma, and your rationale. So one by one, you can all say your opinion. Yes, I'm here to hear. I'm eager to hear.
There is no mode is superior to other mode. Each mode has its pros and cons.
That's a very good general answer. Yes, that is an excellent actual answer. You do every mode has its pros and cons. But regarding this specific case, a COPD case that failed initial non-invasive trial, what will you use? A volume control or a pressure control? You yourself. Yes, I know. Volume control and pressure control modes, you can set them to have the same goals or to have the same outcome. But what about you, specifically in this case? What will you use?
In obstructive lung disease, we need to monitor pressure. So volume control is the best here.
So volume control is the best here. Okay, so we are going to use volume control to monitor the peak pressure and the plateau pressure as a sign of improvement, a sign of resistance. The delta pressure will help you to know that the resistance is improving or no. That's your answer. Okay, that's a good point, a valid point. Does anyone else have another valid preference in using
Mm,
volume control or pressure control in these cases?
In obstructive lung disease, there is fear of intrinsic beep, auto beep.
Yes, yes, that's great.
So I prefer to use pressure control mode.
Yes,
So you
correct.
prefer to use pressure control mode. Do you think pressure control mode can help you preventing and treating auto PEEP or dynamic hyperinflation and auto PEEP?
Yes.
What's the rationale behind this? Yeah. Maybe yes, but I don't know. I want to know your rationale.
It can
I
limit the peak
I
pressure.
limit the pressure.
It can limit the
Limit.
peak pressure. But actually, do you fear from the peak pressure more or the plateau pressure? I will try to make this a little bit simpler. There is the peak pressure, plateau pressure, and baseline pressure, which is the PEEP, the set PEEP or the extrinsic PEEP. So what do you fear more? The peak pressure or the plateau pressure, and the delta peak plateau or the driving pressure, delta plateau and baseline? What's the more
Driving pressure.
harmful to the lung?
Driving
Driving
and
pressure. Driving pressure.
Maybe.
as
So
its indicator for ventilator-induced lung injury.
Okay, peak pressure should be considered also, but actually, it's not an actual pressure inside the lung. So, me myself, I'm not very afraid of peak pressure in obstructive lung disease patient. So, um,
We have
And
to, I
driving
think,
pressure.
avoid air traffic. That will be one thing. So pressure control would be better.
and what do you think about the
This is the plateau
after
pressure.
initial after the initial failure of non-invasive ventilation? What do you think about the sedation consideration in the early phase? Would you consider sedating this patient? And would it make a difference if you are fully sedating the patient or not sedating the patient in the initial mode choice? So if you are going to
Better.
sedate this patient, I will
Yes,
give you
synchronization
another
matters.
tip from my own opinion. If you are going to give sedation for this patient, you fail the non-invasive trial, you have a rapid sequence induction and or drug-assisted induction, intubation, and you think you are going to sedate this patient for a little while. Are you going to, would this make a difference in the initial choice of the mode? This patient is already, you took the decision to sedate this patient. Would it make a difference in choosing the volume control versus the pressure control? In your opinion, by the way, because I don't find a very big literature supporting this, but maybe in your opinion and your common practice, do you think
Doctor, you mean that the patient is deeply sedated, and then which mode we prefer?
if you are going to deeply sedate the patient or moderately sedate the patient, RAS score was just mentioned by Dr. Ahmed Madi. This is a very important tool.
It's okay, we can see, yes.
Yes.
But in such a setting, I mean, in properly controlled or sedated patient, which mode is better, either volume versus pressure? This is your question.
Let's not say better because there is no better mode. Let's say which mode you are going to use. You yourself, not the guidelines, not anything. You are going to sedate the patient, a COPD patient or a severe asthmatic patient. He failed the non-invasive. Which mode do you prefer? You yourself. You are going to sedate him. Does this make any difference in the choice of the mode, in your opinion?
Volume.
Well, I believe this patient
I think
must require conscious sedation. And if he's an acute severe asthma, I prefer ketamine because this have bronchodilator effect. For choosing of the mode, it depends on your experience and what you are familiar with, either pressure or volume. But and in my practice, I prefer still the pressure because this is I'm more familiar, and I'm always afraid from those patients have a lot of secretion, sometimes mucus plug, high peak pressure, trauma. So that's why I'm preferring the pressure mode. At certain times, I put volume just to measure the top pressure and volume, and make sure I'm doing fine and check if there's auto beep or not.
Okay, that's a valid answer. We have another valid answer, but this is regarding the setting from Ariel. He's our one of our best colleagues and one of the most expert in ventilator. But in my opinion, I'm not going to to say that this is a guideline, but the level of sedation and the patient interaction sometimes makes it different in choosing the mode. So sometimes in a passive patient, if I am initially starting this mechanical ventilation, I prefer, in such a patient, I prefer to consider a volume control mode where the flow rate is controlled. But if the patient is partially active, I would consider uh, an adaptive pressure control mode like the PRVC or the autoflow. This is my opinion. I'm not convincing you with it, but this is my practice. If your patient is going to be active, I will consider a partial ventilatory support like the BiPAP, even if in the invasive mode or the spontaneous or shifting to a spontaneous mode. So a level of sedation actually sometimes matter because you cannot fully adjust the flow rate the patient needs or if the patient is active or partially active. That's a drawback of the volume control mode. But if your patient is passive and he's initially ventilated, I think a volume control mode sometimes initially in obstructive lung disease may help. This is my opinion. Patient-specific pathology also, the risk of hyperinflation matters in the choice of the mode. And the most important thing is the patient response. Actually, I don't like to write it like this, but this is how it feels to me. It's a matter of trial and error in some patients. Some patients, you think they are really fit with the volume control mode. You try the volume control mode, they are not fit. They are not fitting in this mode. You shift to PRVC or autoflow or to a pressure control mode in other ventilator, and this patient is very synchronous and very good. Even he is the same patient sedated, he is fully sedated. So sometimes, with no explanation, with no obvious explanation, patient response is very important in choosing the initial mode. So this is our patient. If you are using, what's your initial mode? If you are using a non-invasive, you will use the spontaneous mode, either the pressure support or BiPAP. Actually, BiPAP sometimes is more helpful. But I don't think the BiPAP in the Draeger ventilation fits here because it's not a typical BiPAP in my opinion. BiPAP in the Draeger ventilation is different from the initial BiPAP mode. So we choose the mode. This is step 4. If he is invasively ventilated, we will choose a controlled mode, volume control or pressure control or a dual control mode. This is a misnomer, by the way. Dual control mode, PRVC, or pressure control, adaptive pressure control mode. It's not a dual. You do not control both volume and pressure. You target the volume by controlling the pressure. So PRVC is an option. You can use it as an initial mode. If you are using our autoflow in Draeger, you can use it too. So after you choose the mode, you choose the initial setting. The initial setting choice depends on the mode because every mode has a different initial setting and depend on the lung pathology. Here in our patient, we have an obstructive lung disorder. So if you are going to use a volume control mode, let's take this example. In this patient, he is invasively ventilated. You failed the non-invasive, and this is the volume control mode you chose. What's the initial setting you are going to set for such a patient? Anyone can volunteer and tell us what initial setting he can use.
tidal volume from 6 to 8 milli per kg
So
for ideal
tidal
body.
volume, you are going to use 6 to 8 ml per kg from the predicted body or the ideal body weight, not from the actual body weight. So in an obstructive patient, would you start with 6 or 7 or 8 or doesn't matter? What do you think? This patient
Start
has is
start
not. Oh yes, we can hear.
start low and go slow يعني begin by 6 then increase according to
Both are not high, by the way. In the past, they used in the COPD patient, our seniors used a tidal volume of 10 to 15 ml per kg. This is historical, by the way. They don't use this. But do you think starting 8 or 6 in such a patient? 6 ml per kg or 8 is more appropriate to you?
8.
What's your rationale? If you are going to say 6, you should give a rationale. If you are going to say, even it's an opinion. start 8, Dr. May start 6, and you are starting 8. 8, why 8? Why the higher low tidal volume? It's 6 and 8. 6 to 8 is the considered a little bit not high tidal, it's a low tidal volume. So starting with 6 or 7 or 8, you started with 8. Why, in your opinion?
Can I share,
to
Doctor?
avoid auto beep, which is expected in COPD patient.
To
I have
avoid
some
auto
idea here.
Yes,
I
we can
think
hear you.
in a COPD patient, hyperinflated chest and emphysematous patient, actually these patients will not benefit too much from the tidal volume restriction like the regular or the ordinary people, because
Okay.
the lung is already hyperinflated or the lung is emphysematous already, and it will be a problematic or a problem about the air hunger and the dysynchrony. That's
Okay.
why I think in COPD or emphysematous patient, it is better to start by the higher levels of tidal volume rather than the regular or the other populations,
A
which
higher
indicates,
level, reaching which level? Which level you consider
I mean
higher?
8, I mean upper maximum of 8.
So you will go.
About tidal volume, 8 ml per kg from the predicted body weight.
Yes. So you will
I
go
said,
higher to 10 or 15 mil
no, no,
per
no, no,
kg.
no, 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 not exceeding 8, not
8.
that 10 or 15. I will start by 8.
What if
I
we
will start.
combined both the respiratory rates with the tidal volume? Maybe it gives you a better idea. Which respiratory rate you are going to use in such patient? Respiratory rate. By the way, these numbers are not the ideal numbers. These are just examples. So which respiratory rate you are going to use as an initial
12.
rate for such patients?
10
12.
cycle per minute.
10
From
to
10
12.
to 14.
8 to 10. 8 to 10 will be better.
10,
10,
14,
12.
15, 12. Uh, Okay, you have a preferable number in starting in such a patient, a higher rate or a lower rate in such a
Lower
patient.
rate.
Lower rate.
Lower rate.
If I told you his
Lower
CO2
rate.
is 70, you would choose which rate? His CO2
We
is
are
70
targeting
now.
the pH.
His pH is
Look,
7.29. Okay, we'll make the example more difficult. So would you choose a higher respiratory rate to wash the CO2 or a
No.
modest or an
No,
intermediate rate?
no.
No.
it
Why?
will be
No.
Intermediate.
the dead space.
Yes.
The dead space is counted too much. With the higher rate, the dead space is multiplied by the more frequency breathing rate. That's why I think the higher frequency rate will
Yes.
not be that much effective in ventilating CO2 as
Uh,
much as increasing the tidal volume itself.
It
another
will
problem.
Come on
Also,
expense of
Another problem is okay.
expiratory time.
Why?
expiratory
But yeah,
time.
that's a very good. Yeah, yes, that's a very excellent answer. What does the increasing the rates means to the actual expiratory time? When you have a rate of 10, okay, the respiratory cycle is 6, so 2 seconds for inspiration and 4 seconds for expiration. So the patient
Yes.
can get rid of this tidal volume he gets.
yes.
But when you increase the rate to 20, you think you are washing more the CO2 or making the patient
Mm.
better wash. Actually,
This
this
is
does not
wrong.
this is not very valid for the patient
Mm.
with a very severe obstructive lung disease because you have only very small time for expiration. Instead of 4 seconds, 4 whole seconds to get rid of the tidal volume, you only have 2 seconds. And this patient have an airflow limitation. He has an airway obstruction. So he cannot give, you are getting more and more air trapping. And so you are getting worse in this patient. So increasing the rate is not always ideal in washing CO2, especially in obstructive lung disease patients. So we are giving a lower rates and a higher tidal volume. So at the end,
Mm.
the minute volume is a little bit accepted. The target minute volume is actually this equation. I don't believe in this equation. How or this number? How much minute volume per minute do you think is ideal for a patient by
In
literature?
use settings, 5.5 to 6.
0.5 to 6 watts.
Baseline 5.
So a number of 100 ml per kg per minute. I don't think it fits for all. So I don't think you have a target minute volume, in my opinion, a target minute volume that fits for all patients. You have a target pH to reach, but even this target pH is not to be reached very, very soon. So you can wait a little bit to normalize the pH. Okay. So that's about the tidal volume and the frequency or the respiratory rate. What about the flow? The peak inspiratory flow rate we have in this Bennett, we have a flow rate. What do you think, considering the flow rate, how much is fitting for this patient? He is passive, completely passive because he sedated him, and he is, yes, and he failed a non-invasive, the same patient. Peak
High
inspiratory flow
flow
rate.
rate.
High flow rate.
High and low are something, it's not a fixed number. What's high for you, it's relative.
60 liter per minute.
Maybe low for me. Give me a range of flow.
60
40 to
liter per
80
minute.
or
60 liters
50
per
to 80.
50 to 60.
40 to 60 liter per minute. Okay, let's try 40 to 60. We started a 40 liter per minute or 50 liter per minute. How do you know that this flow is adequate for such patient? And his that's his requirements or his needs.
Hello, 80 from
IA
100.
ratio.
High ratio والوش of CO2.
That's a very good point. Actually, the flow rate does not control the IA ratio in all ventilators. Okay, in some ventilators, the flow controls the IA ratio, like the example we have here. But if you have a dragger as an example, a dragger ventilation, the flow button does not control the IA ratio. That's why you should be familiar with your ventilator. Not in all ventilators. In some ventilators, like the one we are using now, the flow, increasing the flow can decrease the inspiratory time with a fixed volume. So increase the expiratory time and alter the IA ratio. But in other ventilators, the time of inspiration is fixed. So sometimes it's not very easy or the flow does not always control the IA ratio. So please take in mind this. It depends about the other buttons you have here. So if you have time of inspiration fixed like the dragger ventilator, changing the flow will only affect the plateau time. You got this idea? طيب. What about the flow pattern? Square or decelerating? Sometimes in some ventilators you have the option to choose, like this one. In the Hamilton and in the Bennett, you have the option to choose. Let me do this here. This button, what do you prefer? A
Square
square
button.
or a decelerating? And why?
Square.
Give me in this patient. What difference does it make?
Square preferred with COPD.
Decelerating.
Decelerating, I think decelerating is better. It is more physiological. Like the normal looks, I mean, the normal human breathing is starting with high flow rate and then decreasing gradually. It is more physiological. That's why the pressure control mode itself
But
is more
square,
comfortable.
square
Maybe
decrease in
I will
inspiratory
agree
time.
with more physiological, but it's not physiological because it's not the normal pattern, but it's more physiological and better distribution of gases than the square. But in such patient, I don't consider it, and this is my opinion actually, but I don't consider it very physiological. And actually, we are talking about a sedated patient. Let's say again, this patient is sedated. So we're not talking about a normal physiology anyway. So this patient
Square
is
is
completely passive.
better for safety.
Square pattern decrease the decrease the inspiratory times.
Decelerating wave.
Oh, so this is a good idea. It was not in my mind, but it's good also. A square or a constant flow, a square pattern or a constant flow with the same maximum peak inspiratory flow has a lower inspiratory time, as you said, and so a higher expiratory time, so a less air trapping. That's a good idea because if you are using a flow of 60, okay, with a constant flow, it will be lower time. But if you started with 60s and 50s and 40, you will have a higher time for the same flow. So this is an idea. It was not in my mind, but this is a good idea, a valid idea. A square pattern sometimes is better. Okay. Let's talk about this sensitivity. Does it matter here, the trigger sensitivity?
No.
For sedated patient, it's not.
Yes. Actually, we will talk about your all ideas after we finish the whole or your whole discussion after we finish our two cases, because there are multiple things we do not agree, or we are not always on the same page in your choices, but we are just maybe have an
But
exercise here.
actually, this is enriching. This is enriching our knowledge. This is good to have
Yes.
such discussions. So,
So,
yeah.
what do you think about the trigger sensitivity? Here we have a pressure trigger sensitivity, not a flow sensitivity, because Bennett sometimes give you Hamilton sometimes give you the option to choose between pressure trigger or flow trigger sensitivity. So if you have this choice, would you choose to have a pressure trigger or a flow trigger in this patient? Or it doesn't matter? In this patient, this specific patient, he is passive and he started to wake up. Okay, so he can trigger. So I'll tell you, he's not fully sedated now. He started to wake up a little bit. So would you prefer a pressure trigger in a patient with a COPD and risk of hyperinflation, or a flow trigger, or it doesn't matter too much? Some ventilators give you the option to choose. The trigger
Flow.
will be a flow or be pressure. And most ventilator does not give you this option. It only give you a single trigger variable. So if you have the choice, would you choose a pressure trigger or a flow trigger?
Pressure
This
trigger.
patient.
Pressure.
Why?
Because default Swiss flow trigger is higher than pressure
I
So
think
trigger.
you
flow
mean the
triggering.
possibility of auto trigger is less. What you call auto trigger is less, right? Or this is your what you mean? If you are using a flow trigger,
Yes, auto triggering.
so auto triggering can occur more. So this is can lead to a higher prevalence of auto P. Maybe a good answer was not in mind, but a good answer.
But actually, the sensitivity
Yes.
we can change.
Yes, you can
If it
change
is a
the
point.
number, but I'm talking about the variable who will
Okay,
trigger the
this is my
ventilator.
answer to. This is my answer to our colleague, the one who's telling about associated with less auto triggering. I don't think, because if it is there is auto triggering, and we can increase the pressure trigger to +3 or +4, but as an item or a parameter, which pressure or flow, I think flow is more better, because flow is associated with less time to delivery of the tidal volume.
Actually, every method of triggering has its pros and cons also. So there is no preferred method. But I think I do a little bit agree with her that the pressure trigger is less prone or less prevalence of auto trigger or force triggering, because even you are using a good option in the ventilator against the patient, because it's easier for the patient, but this ease comes with drawbacks. Sometimes change water in the circuit, and moving this water can change the flow, the backflow, and cause an auto trigger. So I don't totally disagree with our colleague here that pressure trigger is a less prone for auto triggering, but it's harder for the patient.
Yes.
It's more difficult for the patient. What about the FI2? A simple to choose. What about the FI2? We'll start with FI2 1, or oxygen concentration of 100, and then go low. So what
Yes.
about the PEEP? What do you think about the initial PEEP you are going to choose for your patient?
If your
Lowest
patient
possible peak.
Uh, if the patient is active or if the patient is passive. I tell you two situations. Our patient is active and our patient is passive. Our patient was sedated, he was passive, so he was fully sedated, he was passive, not sharing in the ventilation. So which PEEP you will choose? And then he became active. You awaken in him and he's less sedated and he became active. What's the level of PEEP? Would it make a difference in our choice, or you are going to choose the same level of PEEP? And at first, he didn't have any dynamic hyperinflation or auto PEEP, but after a while, you monitor the auto PEEP and you find that he has significant auto PEEP. So, what's the choice of PEEP in those three conditions? Patient was passive, then he became a little bit active, then he has a significant auto PEEP. So what's about the extrinsic PEEP or the set PEEP or the PEEP of the ventilator? How much you are going to set it? Any
For the
suggestion?
passive patient, I think it may be appropriate to start with the expiratory held maneuver to check how much actually he's trapping air or how much there is auto beep, and then we adjust the external beep accordingly.
His total PEEP is 10 centimeter. Is 10 centimeter, while your set PEEP is 5. So you have an intrinsic PEEP of 5. Would you change the PEEP or not? You started with a PEEP of 5 and you have an intrinsic PEEP, total PEEP is 5. You made an expiratory hold and you find that the PEEP instead of 5 it's 10. Okay. Would you change, and how much you are going to change the PEEP?
So the set beep is 5?
Yes, and the total
So I
PEEP
will
is
increase definitely.
10.
I will increase it to reach the patient level of 10, or sometimes yes, of 10. So it will be easier for the patient to when he wakes up to trigger. It will make triggering is more easy. I mean, if he has a total beep of 10, and our set beep value is 5, so we will change the set value to 10.
80% of total of
We use
Yes.
80% of intrinsic beep.
Sorry, yes,
Total.
80% of I will. Yes.
It's total beep.
80% of the total PEEP in
Yes.
all patients, active and passive. So do you think that this fits for all patients, an active patient and passive patient, to give him an 80% or 70 to 80, sometimes some reference say, from the total PEEP to treat the intrinsic PEEP? So we are going to treat the intrinsic PEEP with applying an extra extrinsic PEEP. Does it fit for all patients, passive
No,
and active?
passive only.
Okay.
No, actually, it is for the active patient because this
Yes.
applying external beep is aiming just to make synchronization. It will not treat the auto beep itself. It will
Yes.
just make the triggering easier for the patient. So it will be for the active patient, not
So
for the passive one.
this is more valid for the active patient. That's a good answer actually. We have an answer from Dr. Mohamed Amin, a similar name. Dr. Mohamed, I know him for sure, but he has a similar name. That effect of PEEP on the plateau pressure. What's the effect of PEEP on the plateau and the peak pressure? What do you think? When you increase the PEEP, what will happen to the plateau pressure and to the peak pressure?
increase.
In all patients?
Both increase.
So increasing the PEEP, does it increase the plateau? The PEEP is the baseline pressure. So logically, if you increase the PEEP, you will increase the higher pressure on top of the PEEP. You have a PEEP, okay? So if you did increase the PEEP from 5 to 10, do you think that this increase in the PEEP will be reflected at the same amount on the plateau pressure and the peak pressure? What do you think in all patients? Maybe in our patient, yes, but what about do we have exception in this? Increasing the PEEP, does it raise all the above levels of pressures above it? I know we are going in too much side talks, but I think this is an important question to answer. What do you think about the effect of PEEP on the other pressure above it? The plateau pressure and the peak pressure? Anybody have an answer?
Both of them should be increased.
Always?
In passive patient, Dr. Muhammad, increase the both of peak and the plateau pressures.
I'll give you an
But
example.
it's
I'll
Zero
give you
oxygen.
a
So
clue in my question. Does it matter this patient is recruitable or not recruitable or fully overdistended on the effect of PEEP on the plateau pressure?
in a recruitable patient, pressure will decrease. In over-distended
I think
patient,
so.
pressure will increase.
I think so. If this lung has a potential for recruitment, so increasing the PEEP will will improve the lung not in the moment, not instantaneously, but after a while will improve the lung compliance. So I think it will improving the lung compliance will decrease the plateau pressure. So sometimes we use this as a test actually to know if the patient is recruitable or not by increasing the PEEP and detecting the effect of this PEEP on the compliance and then the plateau pressure. So the effect of PEEP is not always directly proportional with the plateau pressure. It does not increase the plateau pressure for all
Yes,
patients.
right.
Okay. Right. We have said this patient mechanical ventilation. What do you think if this patient was asthmatic, the asthmatic case? What the level of PEEP you will set for this patient? Would it matter a change of level of PEEP between this COPD patient? You said the PEEP of 5 or 50% if of the total PEEP or 70% of the total PEEP according to his passive or active. But what if he's an asthmatic patient? What do you think? Would it make a change in the choice of the PEEP? The female case that was asthmatic. Would you make a different choice of PEEP in her? Anybody has a suggestion? Difference?
Bronchospasm.
Yes.
Bronchospasm help of oxygen if you nototropic is there. If you
Actually, the aim of this interactive session is to hear from you, your opinions, your different strategies and techniques in ventilation. So don't worry, there is no wrong answer. You are just hearing from you. I don't think there is an agreement on initiation of mechanical ventilation. There is an agreement of the targets and maybe some agreement of the weaning protocols, but in the initiation, there are many schools. So I want to hear from you. What do you think about PEEP choice in COPD patient versus the asthmatic patient? We have
Please,
a
please
COPD
be not
patient.
admitted.
Will start with PEEP of 5. What if this patient was not a COPD, he was an asthmatic patient?
3. Start with 3.
3. A lower PEEP. Actually, I agree with you. In a severe asthmatic patient, I would consider lower PEEP level in my practice than the COPD patient. I start with a PEEP of maybe 3. Sometimes I reach 0 initially. I mean the initial PEEP. But in a COPD patient, I would prefer a PEEP of 5 to 8 initially till measuring the auto PEEP and the other. But what's your rationale for this? Using a lower PEEP, lower initial PEEP in asthmatic patients. It's okay. You can answer. You can say your what do you think about why did you use the lower PEEP in the asthma patient, not the higher level of PEEP? Okay. So let's say to sum up of this.
Increase
Yes, I can
driving
hear you.
pressure.
Increase driving pressure. What do you need a higher driving pressure? The driving pressure, by the way, is the difference between the plateau pressure and the baseline pressure. Okay, we sometimes it was a newly introduced term, maybe 10 to 15 years only. I don't know the number of years actually, but before that we were not aiming to target a driving pressure. But the last few years we just studies made us notice the importance of this driving pressure. So the driving pressure usually we prefer a lower driving pressure or a higher driving pressure. What do you consider when you are managing a patient and you on the mechanical ventilation? would you prefer to have a low driving pressure or a high driving pressure?
Low driving pressure.
Lower driving pressure. Okay. But in the asthmatic, what does the driving
Obstructive.
what does the term driving pressure
Obstructive.
means? What does it mean, and what does it help in? It's very harmful to the lung to increase the driving pressure, but it helps a little bit in something. What its use?
Improve ventilation.
Okay, improve ventilation. So you would prefer a higher driving pressure in COPD or a modest or a low driving pressure?
You will
higher.
be modest
Mm.
for to avoid O2B.
Maybe it will not. Yeah, it will not. It's not the aim in avoiding auto peep. Okay. Okay.
Obstructive lung disease with a higher driving pressure.
The problem in asthmatic patient is airways resistance.
Yes. Okay. The problem is mainly is airway resistance. Okay. Maybe you have a resistive problem also in COPD patient. Both of them has a problem in resistance.
I put
ما in asthmatic no remodeling.
This is the pathophysiological point of view, but what does it make a difference in the acute exacerbation between both? We have both are having a very high exacerbation now. So what's the difference?
I put high beep from 5 to 8 in COPD patient to
Okay.
avoid the atelectasis and the collapse of alveoli. But in asthmatic patient, the problem is airways. I don't need for high beep يعني.
Okay.
Only 3 is enough here.
So we're going to go through our case to finish our case scenario. Okay. So in the COPD patient, to sum up you all have said, non-invasive ventilation should be considered. It's actually this is only a guide for you. If you have two of these factors, respiratory rate above 25, acidosis, respiratory acidosis with a high CO2 and the pH less than 730. Dyspnea, use of accessory muscle, and paradoxical breathing pattern, you should consider non-invasive ventilation. I think bi-level mode, so BiPAP, which is called BiPAP in most ventilators, is an ideal mode to consider. Bi-level BiPAP, not APRV for sure. We are going to use BiPAP, but pressure support mode, spontaneous mode with pressure support, CPAP with pressure support, sometimes can be used. Most of us use it. In case of invasively ventilated patient, volume control or pressure control mode can be used. But I prefer, in my opinion, initially, if you are going to sedate the patient, I prefer the volume control mode. Take care of the respiratory rate and the tidal volume and the minute volume. An initial tidal volume of 8 ml per kg is preferable, and the rate of 8 to 10 is preferable. At an initial time of inspiration of 1 second from point 8 to point 1.2 is considered acceptable. A peak flow rate of something like 60, even sometimes above 60, if the patient is partially active, is preferable. I don't prefer the descending flow pattern. I will use the constant initially, the constant pattern. But in some literature, they are saying about the decelerating pattern. It's accepted in some papers and some literature. A PEEP of 5 in COPD patient or 50% of the O2 PEEP should be initially used if the patient is passive, but you can consider a PEEP of 80% of the O2 PEEP if the patient started to be active or partially active or during the weaning period. If you are going to wean the patient, if you are going to shift to the spontaneous mode, I think considering a higher PEEP in COPD patient, something like 75 to 80% of the measured total PEEP will be helpful. Always monitor for dynamic hyperinflation and auto PEEP using the flow time curve or the flow time scalar, or using the pressure time scalar while applying an expiratory hold. Um, this is to minimize the hyperinflation of the O2P. You should provide the longest possible time of expiration. The longest possible. It's not always feasible, but you should decrease the time of inspiration and increase the time of expiration as much as you can. Okay. The plateau pressure should be maintained below 30, as we all said before, and the driving pressure preferred to be less than 15 and sometimes less than 13. What about the asthma patient? It's more difficult. If the asthma patient reached the need of ventilatory support, it's much more difficult than the COPD patient. Okay, non-invasive, if used, it can be used. It can be used for sure, not contraindicated, but it should be used cautiously with a strict monitoring. Actually, in the COPD patient, we can start the non-invasive ventilation in the ER or even in the ward, sometimes in the ward. But in asthma patient who needs the non-invasive ventilation, it should be only in the ICU setting, and the intubation should be ready. Okay, this is the big difference between them. COPD patient actually sometimes have a domiciliary ventilation or home ventilation at home, but the asthma patient which needs a further respiratory support should only be managed inside an ICU, in my opinion, not in the emergency department, not in the HDU, not in the ward for sure. It should be managed in the ICU. Volume control or pressure control after intubation can be used, any of them. It doesn't matter, but I do prefer to use the volume control initially if the patient is passive, or adaptive pressure control or the PRVC if the patient is partially active. And this is a suggestion for the initial setting in the asthma patient. So sometimes you can accept a CO2, a high CO2 initially, like the one we accept in the ARDS, but here we can accept it in the severe asthma patient with a pH for sure higher than 7.2 and the CO2 ranging 45 to 80. Adequate oxygenation should be reached. Saturation of 88 to 92 is accepted in COPD, and even saturation of 90 to 92 is accepted in asthma. In severe asthma patients, the difference that sometimes we need more sedation and paralysis in the early phase, in the first 24 hours in the asthma patient, even more than the COPD patient. That was our talk today for the mechanical ventilation of obstructive lung disease, both
Excellent.
spectrum, the severe asthma and the COPD patient. I'm sorry for making you late today. Sorry for taking too much time, and thank you again for Dr. Hassan Khalid, my professor and my mentor. We are ready for any questions. If you have some questions or comment or suggestion for what we said today, because as we said, there is no too much agreement in some in the initial ventilatory setting. I think there are many schools in the initial ventilatory setting, especially I think in the ARDS it's almost settled. On the restrictive lung disease, it's almost settled the initial setting. But in the obstructive lung disease, there are many differences between the different schools in managing this ventilatory management of this patient. So any comment or any suggestion or any question?
First, thank you very much for this extensive lecture about COPD and asthma and different ventilatory support interactive. And we take your permission to put it in our site of Journal Club on the YouTube, Hassan Khalid Journal Club. If you agree, we recorded it. Do you agree?
طبعا دكتور حسن for sure. ده الايم اساسا ان احنا اي حد يعني
if anyone want to review this very elegant lecture, he can go. We usually Dr. Omar, who is taking care of that from Aswan, make this job by putting the record on this site on Journal Club, and you will find other important lecture over the last 3 years or 5 years. I don't think in anybody after 1 hour, 15-minute extensive lecture. I don't think most of them want to sleep.
Okay.
Thank you very much. Everybody
طبعا.
write for you that thank you, excellent, marvelous. You can read the chat to be happy.
I think we have one comment, Dr. Hassan, please, from Dr. Ariel, for our
Yes.
friend from yes.